Today we're going to be talking about small bowel obstruction. This is one of those videos you've been waiting for. I'm going to take you through a clinical case, and if you stick around until the end, I'm going to show you what I found in the operating room. We're going to go through the causes, we're going to go through the history and the exam. In the next video, we're going to be talking about the workup and the treatment of small bowel obstruction. So today, it's going to be awesome. Let's do it. Welcome back to Citizen Surgeon. My name is Dr. Eric Pearson. I'm a pediatric surgeon, and I'm pumped that you're here to join us today to talk about small bowel obstruction. Now, this is a critical topic in general surgery. It's one of those topics that you have to know in and out, not only for your exams, but just for the daily practice of a general surgeon. We're called often to the emergency room to evaluate somebody with a small bowel obstruction, and daily, making our rounds, we're making active clinical decisions on patients with bowel obstructions, when to operate, when not to operate. And today we're going to be talking about the causes of bowel obstruction. I'm going to teach you how I think about bowel obstruction, starting from the inside out, okay? We're also going to be talking about the history and the physical exam. In the next video, we're going to be going through the workup and the treatment of bowel obstruction. So, hang on to your hats, let's get into it. But first, let's do a clinical case. Let's get into it. So this is an 18-year-old male who presented with central non-radiating abdominal pain, extremely crampy in nature, that started last night, was intermittent with severe pain every few minutes. 10 out of 10 in severity, aggravated by movement and pressure, relieved by nothing, and associated with bilious emesis and some loose stool. If you notice, I took the SRN OPD SARA approach, and you haven't checked out that video on how to take a pain history, how to take a history in surgery, I definitely recommend it, because that's one of those things I do every day the same way every time since I was a third-year medical student. Now, when I examined this patient, they were distressed. They were lethargic. Their vital signs had tachycardia. In examination of the abdomen was distended. It was very tender. So, as part of the workup, I did get an x-ray, and it showed this. So you can see there are some distended bowel loops, but there's also this radio-opaque object right in the central abdomen. Can you guess what this is and why it was causing this obstruction? We'll get to it in the end. So let's get into the causes of bowel obstruction. So when you're on rounds with your attending, they may ask you, hey, what are some causes of bowel obstruction? And if you have kind of a disorganized approach to how you think about bowel obstruction, you may only be able to name off a couple. But if you have a systematic way that you think of things, you'll be able to create lists of problems. And this is the systematic way that I think about bowel obstruction. You have the intestine. The intestine is a tube. So if something's going to obstruct that tube, it's either going to be coming from something in the middle or the lumen of the tube, something within the wall of the tube or intramural, or something outside pushing in or kinking the tube. So in bowel obstruction, the list of things, or the causes, can either be intraluminal, intramural, or extraluminal, okay? So let's get to the intraluminal causes. So when we think of intraluminal causes, the first one that comes to mind may be foreign body. So people swallow all sorts of things. Often I'm taking coins out of the abdomen, but people can swallow all sorts of different things, and these can obstruct the small bowel. Second thing would be a bezoar. So, for example, a phytobezoar, a food bezoar. You can also have a trichobezoar, a hair bezoar, and these can be clumps of hair or clumps of vegetable matter that forms a ball and then obstructs the small bowel. So I've taken out plenty of trichobezoars from the stomach, and I've also taken trichobezoars out of the distal ileum, causing an obstruction. Another intraluminal cause would be a gallstone. So for example, gallstone ileus. When you get a fistula, and a fistula is a communication between two epithelial surfaces, okay? But you can get a fistula between the gallbladder and the duodenum, and a gallstone can go through that fistula, go down the small intestine, and typically obstructs in the terminal ileum. All right, so those are three causes of intraluminal obstruction. So that would be foreign body, bezoar, or gallstone. Let's get to intramural. So when we get into intramural, the intestinal wall are things that are intrinsic to the architecture of the intestine. First, I think about congenital problems. So can you have an atresia, or can you have a web? In future videos, we'll talk about intestinal atresia, the different types. I'll get you comfortable with that. But that's one cause, would be congenital problems. Within congenital is also a duplication. So can you have a duplication cyst of the intestine, and that can cause an obstruction. There are neoplastic. So we have primary small bowel adenocarcinomas, or perhaps a primary carcinoid tumor of the intestine. These are rare, but they can cause an obstruction. We also have metastatic disease. So there are different tumors that can be metastatic to the small bowel. Sometimes that may be an ovarian, so ovarian carcinomatosis, or another tumor causing carcinomatosis, implants in the small bowel that could cause an obstruction. And then, of course, we have traumatic. So for example, if a young person gets involved in a motor vehicle accident, or perhaps involved in a bicycle accident where a handlebar injury comes to the abdomen, you can get an intramural hematoma, and that can cause an obstruction. Other reasons for small bowel obstruction can be endometriosis, also inflammatory. So Crohn's disease can have a stricturing component, and that can cause a small bowel obstruction. I've done strictureplasties, small bowel resections on young people with obstruction caused by Crohn's disease. And there are different infections. So for example, tuberculosis or actinomyces or diverticulitis, these can cause inflammation, stricture, and of course a small bowel obstruction. Okay, let's get into the extrinsic causes, or reasons for small bowel obstruction from external compression. So the most common cause of small bowel obstruction falls into this category, and that would be adhesions. And that needs to be on the top of your list, especially if somebody has a surgical history. Second would be hernias. So importantly, have you done on your physical exam a hernia examination of the inguinal canal, as well as for femoral hernias that can cause bowel obstructions? And these have a higher risk of getting strangulated or ischemic and causing sepsis, septic shock, and of course a poorer outcome. So really important to do a hernia exam when you're evaluating for bowel obstruction. Extraluminal can also be neoplastic, so tumors in the abdomen can be compressing the bowel. Intussusception is a problem that I see as a pediatric surgeon, typically around the age of 2 or 3 years old, where you get enlargement of the lymphatic tissue in the distal ileum, and that causes an ileocolonic intussusception. So this is another cause of obstruction. And then abscesses or inflammatory collections in the abdomen can cause obstruction by external compression. When we look across the board, what are the most common causes of small bowel obstruction? Well, I already told you adhesions is number 1. Neoplasms or cancers causing compression is number 2. Hernias and Crohn's disease follows those two. Then, of course, miscellaneous or other can be any one of those causes that we just talked about. So now we're going to talk about the pathophysiology, or what happens in bowel obstruction that leads to that history and those findings on physical exam. So let's take a look at this diagram now. I drew this, it's a stick figure theater. That's what I'm good at, but it makes it very clear, very simple for me to understand these concepts. So you can see here we have a lumen of the intestine, all right? The intestine is a tube that I talked about, and whether it's intramural, intraluminal, or extrinsic, somehow you can get a bowel obstruction. In this example, let's use gallstone ileus. So in gallstone ileus, like I said, you may have a fistula from the gallbladder to the duodenum. A gallstone passes through that fistula, gets obstructed typically in the distal ileum. So what's happening in the bowel? Now, early on in a small bowel obstruction, you get increased peristalsis, both before the obstruction and after. So early in the course of an obstruction, you can actually get increasing loose stools or diarrhea as there's increased peristalsis. That small bowel is trying to push this object through. Now, despite all that pushing, stuff isn't going through because it's obstructed, okay? And what happens is you get increased fluid in that proximal dilated segment. You're also going to get increased edema of the bowel wall if that obstruction continues. Now, hours or a day or a couple of days into an obstruction, you're going to get this stagnant fluid proximal to that obstruction, or in our case, proximal to that gallstone. Now, typically, The small bowel effluent, or the contents of the small intestine, are sterile. They're moving through, as we talked about in small bowel physiology video, link to that above. There is an immune function of the small bowel, and when the contents are passing through, they're typically sterile. But if they're stagnant, then we start to get bacterial overgrowth, and that bacterial load starts to increase. And the common bacteria that we see in the small intestine during obstruction are Escherichia coli, or Klebsiella pneumonia, or Streptococcus faecalis. Those are 3 bacteria that are common, with E. coli and Klebsiella being the most common. When you have bacterial overgrowth, you can get bacterial translocation. Now you're taking that sterile peritoneal fluid and it's becoming inflamed. That's going to lead to SIRS, or systemic inflammatory response syndrome. And this is where you really start to get those clinical manifestations. The increased edema and fluid is going to lead to hypovolemia. They're also going to be vomiting, which is going to lead to electrolyte disturbances. That bacterial translocation is going to lead to fever. It's going to lead to a SIRS response, and of course abdominal tenderness, maybe even peritonitis. And there's one particular type of bowel obstruction where this starts to progress at a very rapid rate. Patient can get very sick with dead bowel. So what is that one type? All right, so you might have come up with a couple, but I'm thinking about closed loop obstruction. This is where you have a single point of fixation for, in this example, it's an adhesion that's causing a closed loop of small bowel. When you have a closed loop of small bowel, you're going to lose that blood supply as the bowel becomes increasingly distended, tense, and edematous. When you lose that blood supply, you're going to get ischemia. That is going to lead to intestinal necrosis and then perforation. The other 2 you might have thought of might be a Peterson's hernia or an internal hernia that causes ischemia, or malrotation volvulus that can cause ischemia. So things that have an increased risk of causing ischemia, whether it's a closed loop obstruction, malrotation or an internal hernia, or an incarcerated inguinal hernia or femoral hernia, those can lead to a rapid progression of this pathophysiology. Now, like we talked about, what are the consequences of bowel obstruction? You have electrolyte abnormalities. You're hypovolemic because you're vomiting. You're also not able to absorb all that fluid. This can lead to shock. And as we talked about in the shock video, that's a problem with end organ perfusion. And as bowel obstruction progresses, you can get ischemia and perforation. That will definitely lead to sepsis and septic shock, and we've talked about that before. One other thing to think about is as the abdomen becomes increasingly distended, it's going to put upward pressure on those diaphragms, and so you can also get somebody that comes in short of breath and difficulty ventilating, and that's why hypoventilation is also a finding in bowel obstruction. So let's get to the history. What are those questions and what are the typical answers that you're going to see in bowel obstruction? Let's talk about the pain history. So we've gone through pain history before. SRN OPD SARA, that's the one that I use. And so it's typically a central type of pain. It's non-radiating or maybe even radiating to the flanks or into the pelvis. It's typically very crampy in nature. The onset can be hours to maybe a day, and of course perhaps more, but it can be quite a short onset. It's an intermittent pain. If it's constant, then you got to start worried about perforation or ischemia. But it's typically an intermittent pain every 4 to 5 minutes and maybe even less than that. The pain can be very severe. It's typically aggravated by movement or pressure. It's usually relieved by nothing. Maybe pain medications or emesis can be relieved with an NG tube placement. Okay? And then it's associated with nausea, emesis, hypovolemia, and even sepsis. Now this is typical in the history, but there are a few important points to think about. So in distal obstructions, you may not see a lot of emesis if it's happening far down the small intestine. Remember, we said the small intestine may be up to 15, 16 meters in length. So if you have an obstruction in the very distal small bowel, they may be presenting with pain before emesis. Thinking about it the opposite way, in very proximal obstructions, nausea and emesis, or bilious emesis, may be the most likely findings in somebody with a proximal obstruction, and they may be without pain. It's common when we think about bowel obstruction that they need to be obstipated, so that means no flatus and no bowel movement. But this is usually a late sign. So if somebody is having loose stools, you can't say that they don't have an obstruction. They do not have to be obstipated to have a small bowel obstruction. It's typically a late finding. And then, like we talked about in the pathophysiology, if you do have feculent or very stinky, smelly emesis, that's because of the bacterial overgrowth. And that's also a late finding. So if somebody has really stinky, foul-smelling vomit, that means they have a tremendous amount of bacterial overgrowth and the obstruction has been there for a significant period of time. So let's get to the physical exam. So when we're doing our physical exam, I have a particular system that I use, and that's Chandler. I talked about it in the acute abdomen video. And Chandler stands for color, hydration, alertness, nutritional status, disability, limb symmetry, external support, and respiratory distress. So I go through those things. And in a patient with a bowel obstruction, they may be pale, they may have poor hydration, dry mucous membranes, they may be lethargic, like the patient in our clinical scenario, very tired because of that hypovolemia. They could have decreased nutritional status. Maybe this is a patient with a cancer or long-standing Crohn's stricture and has not been able to take in adequate nutrition. You might not find any problems in the disability neurological exam or limbs, but on external support, maybe they have a nasogastric tube in for drainage, and they may have hypoventilation or some difficulty breathing if their abdomen is quite distended. When it comes to vital signs, they can be tachycardic, also can be hypotensive, and they may have a fever, shock, or sepsis, depending on if they have bacterial translocation or perhaps even ischemia or perforation. When it comes to the belly, in distal obstructions, they can have a very distended abdomen. Of course, you want to look and observe for any scars. Have they had any previous surgery or previous laparoscopy or laparotomy incisions? When you feel the abdomen, is there tenderness in a particular area? Do they have diffuse peritonitis? You need to do a hernia exam, inguinal hernias and femoral hernias. And of course, a rectal exam. You're going to check not only for masses or obstruction in the rectum, but you also want to look to see, is there any blood that would suggest perhaps an obstructing neoplasm or even intussusception. When we look at bowel sounds in a bowel obstruction, sometimes we hear these high-pitched sounds, almost like borborygmi when you have those stomach growls. And that can be early in a bowel obstruction. Typically, later in a bowel obstruction, when it becomes totally fluid-filled, those sounds will go away. Now, of course, this was an abbreviated history in a physical exam. You do want to take a complete history, going through the past surgical history, medical history, medications, allergies, all of those things need to be accounted for, and a full physical exam of all of the systems needs to be done in any patient that you're examining. All right, so what you've been waiting for, let's get to the clinical case. So this young person came to the emergency room with abdominal pain, dissension, emesis. On exam was quite lethargic with peritonitis. On the x-ray, we saw those metallic objects. Do you have any idea what they are? I'm going to break it to you here in a minute. Well, I took this person to the operating room after resuscitating, starting some IV antibiotics because of that peritonitis and fever. And in the operating room with a midline exploration, I identified an internal hernia. So this patient had swallowed magnets. And when the magnets went through the intestine, they went through at different rates. And so some magnets in the proximal intestine, saw some magnets in the distal intestine, and connected. Okay? And when that happens, they get an ischemic area of bowel between the two, and the magnets will just find their way and create a hole between the two. Now, not only did that happen, but the patient got a hernia of bowel through that bridge created by those two loops connected by the magnets. So I went in, I separated the bowel, I ended up doing a small bowel resection, putting this together. I ended up closing up the patient, extubated, they did great, went home after a couple of days. So the important lesson from here is, number one, magnets are really dangerous, okay? They're not toys, they're dangerous. Number two is being able to understand what the differential diagnosis is in small bowel obstruction, and knowing from your history, physical exam, and some simple tests that a patient needs to be in the operating room to have that problem corrected. Okay, in the next video, we're going to go through the workup and treatment of small bowel obstruction. I hope you enjoyed this today. If you haven't had a chance to subscribe, definitely subscribe. If you want to leave some comments, I will definitely get back to you. And check out citizensurgeon.com. I have a great blog on there. I blog a few times a week. And on Saturdays, I have a newsletter I send out called the Saturday 6. It's the 6 things that have kind of inspired, educated, or somehow changed my life every week. And I like to share those with you guys. So good luck, study hard, be safe. I'll see you next time.